Seeing no questions, I'll introduce the first speaker, who you've already met briefly, Dr. Alexandre Canheu, who's joining us by video from Brazil. And I started my comments by saying I had some pessimism about whether or not this group could reach a consensus about Chiari definition, but it sounds like our colleagues in Brazil may have lapped us on this one, because Dr. Canheu is going to give us a talk on the results of the Brazilian Chiari consensus efforts. Dr. Canheu, thank you.
Thank you so much. Can you hear me nicely?
Yes.
Yes.
This is my place, Londrina, and the hotel which we held the meeting. And yes. My concern, Londrina is located at southern Brazil, in the Paraná state, near from Curitiba and São Paulo. The city was founded by the Englishmen regarding London, just because its daily morning fog very similar to the English famous city. And here's, sorry by the minor caption, but this was our 2 days consensus program encompassing all the main issues about pediatric lung malformation. Is it good?
Yes.
Are you hear me? See? Okay. As one can see, the talks were pretty well attended, with full rooms. This is a picture of the video conference with our colleague, Dr. Brando Rock, who's kindly spent 2 hours in front of the camera and could join us. Yes. This is the photo of the last day meeting and the staff available at that moment. And the consensus was built because there were being done several misconducts about pediatric Chiari 1. And also we used to face the lack of Brazilian guidelines for the disease. At the same time, we planned some kind of tools that could help us to check how strong was the knowledge of the attendees about Chiari 1 malformation, and somehow we would like to test if this could change the misconception of the majority of the attendees. Aside this, there's been lots of lawsuits obligating the Brazilian health system to pay surgeries in Barcelona Chiari Institute. As you may know, the Chiari Institute of Barcelona is diffusing the idea they have new interpretation to various diseases of neurexis. New interpretations, my folks, or new maybe misinterpretations. I don't know. They can see every patient or customer that seeks them for medical attention, and they can speak also and understand any language one speaks. The treatment, the surgical treatment was trademarked as Phylon system. Only them can perform at the very best state of art. But one theory can treat all the neuroaxis illness, like Chiari 1, Syringomyelia, scoliosis, vascular impression, etc. Maybe it's the new panacea, folks. As you can see at this slide, our Brazilian colleagues have just published this paper analyzing the effect of the Phylon terminalis section for Chiari 1 malformation. And they did a systematic review and concluded, as one could expect, that this kind of surgical treatment is experimental, with level 4 of evidence. Once here, going in our idea, we first set the naming of the disease. Following Dominic Thompson and Andrew DeRocco publications, we prefer name it as deformity rather than malformation, since there are several conditions could lead to Chiari 1, and so we prefer the term deformity. About the imaging, the consensus jury decided to point 5 millimeters descendant tonsils as the minimum to diagnose the deformity. As you can see here, as you know, we used to draw a line between the basion and the piston, and the tonsils mustn't descend beyond this line. The Brazilian consensus so stated that 5 millimeters below we should call Chiari. At the coronal view, mimicking this great work from Tubes et al., it's very important to analyze the images, not only the middle sagittal plane, and also at coronal views, since the tonsils, as you know, are not mid-sagittal structures, but maybe asymmetrical at this point of view. And for the other hand, flexion, extension movement can also change the tonsils position. The Chiari 1 disease, when asymptomatic, may present itself with or without Syringomyelia. We suggest, in cases without Syringomyelia, to be conservative, perform neuroaxis MRI, redo the consultations and the clinical analysis each 6 months, repeat craniocervical MRI next year, and if normal, after 2 years, and if normal again, after 3 years. But in cases in which Syringomyelia is a significant finding, we rather prefer operate on the patient since the threshold for him or her and after the deterioration may be pretty narrow. About the symptoms, we divided into two main groups: minor symptoms, major symptoms. The minor ones are those non-specific, like headaches, pretty characterized numbness, paresthesias, and the major ones are all the symptoms related to motor pathways, as well cranial nerves related, or central apnea, or even signs of central cord syndrome or progressive scoliosis. For the symptomatic patients, we suggest to perform neuroaxis MRI, dynamic studies, CT scan or MRI. And for those who complain about snoring or other sleep disorders, sleep studies like polysomnography. And during the investigation, if hydrocephalus appear as a concomitant finding, here's the Chiari 1, here's the hydrocephalus. And we always try first, obviously, the endoscopic third ventriculostomy. For the surgery itself, here is the position of my preference, always padding the points of contact and getting the shoulder out of the operation field. Here is my suggested incision with a little extension upwards, and in order to dissect the pericranium for the likely dural patch if needed. This picture shows the occiput exposed. Look at the spared pericranium folded upwards, the occipital schema, and this position of the posterior arch of C1. This bony removal must be at least 3 centimeters up above the foramen magnum. Maybe it's not necessary go as far as lateral as I went here, but also never forgetting to remove the posterior arch of C1. And at my surgeries, I always check during the procedure with this ultrasound probe, looking for space in the cisterna magna after the bone decompression. This paper shows the same concern, and we can see the overcrowded cisterna magna previously to the opening, and this image just after the treatment. Here is one example of duroplasty, sometimes when it's desirable to expand the cisterna magna. If we deal with a case harboring also instability, as you can see here, look the dynamic CT showing the dens insinuating upwards during head flexion. So we shall decompress and perform the posterior fusion accordingly each case or each surgeon experience. This is the same case of the last slide, showing here the retroflexed dens is maintained, but we can see improvement of the Syringomyelia and all the symptoms of this patient ceased after the surgery. And summing up our flow chart, we can summing all the things up. Every case of Chiari 1 deformity should be screened, of course, for secondary causes as hydrocephalus, craniosynostosis, tethered cord, or metabolic disease. And if it's a primary CID diagnosed incidentally and asymptomatic without Syringomyelia, we follow this patient up, as mentioned before. If we find Syringomyelia in a symptomatic patient, it should be better because may have another threshold for improvement, as I told before. At the right side of the flow chart, we can see the symptomatic patients. As we discussed it before, we screened the neuroaxis with MRI, dynamic CT, or MRI and polysonography in the cases who were snoring complaints. If we have a Chiari 1 child with no ceilings at all, we suggest to do posterior fossa decompression and put intraoperative ultrasound to check out the cisterna magna. Once free, the surgery is done. Whether overcrowded, autologous uteroplasty is advised. For the other hand, if there's no, if there is a syrinx, our protocol suggests posterior fossa decompression plus uteroplasty, regardless the result of intraoperative ultrasound result. After discharging the patient, if the symptoms relapse or persist longer than 6 months on the follow-up period, we recommend a second lung surgery with revision of the PFD plus uteroplasty plus tonsillar coagulation, just to improve the room of the posterior fossa. And finally, if the exams show vertebral basilar impression with, for example, vertoflexious dance, we suggest decompression and posterior fossa plus posterior fusion. We conduct a survey during the consensus encompassing 2 questionnaires with the same questions, just to check out how the meeting could change the conduct on Chiari 1 deformity. At the opening of the consensus, we sent 27 questions to the mobile of every attendee using the SurveyMonkey app, and 34 answers were assigned. At the closing of the consensus, the same 27 questions with 33 answers. The results were compared and with this statistical analysis. This was the first question in which we had statistical difference. See that the majority was focused on following the child up until 11 years old. And at the end of the meeting, there was a shift in this outcome, showing the majority of the attendees, here 27% and 21% together, choosing following the first 3 or 4 years old. And still some keeping the idea of 18-year-olds, and the P was less than 1% for this question. The question number 4 asked, which is the most frequent late symptom among hydrocephalus, spasticity, nocturnal respiratory symptoms, scoliosis again, and muscular atrophy. In the beginning, we had 47% choosing scoliosis. At the end, after discussion, we've got almost 70%. And 36% of nocturnal respiratory symptoms. In the P was about 1%. In the question number 5, we got also an interesting situation again. We asked about Chiari 0 and 8 attendees, 23%. Answered no, it doesn't exist, or I don't know, I never knew this situation. After the meeting, we're able to convince the majority, as you can see here. But still 2 attendees, or 6%, were yet stuck on that idea. Maybe they went to the toilet during the classes. Yeah, maybe. So 93% of answering yes. And concluding the statistical analysis, the last question in which we have a nice statistical difference was about the number 19. In your opinion, related to Chiari 1, every case should be screened for instability. Initially, yes prevails, with 58% of the answers. After the meeting, the answers changed significantly, showing 63% of no. We definitely might not seek every case for instability, as you know. And just for notice, this work has been written and been accepted for publication on child nervous system. And it may be published next month. And this is the letter of acceptance here by the Professor Divoco. So, concluding, the Brazilian Chiari 1 consensus effort, we are able to outline a flow chart for the management of this complex pathology based on current standards of all international societies of pediatric neurosurgery. The Chiari 1 deformity has become increasingly studied, analyzed, and debated in Europe, Asia, and America with the same energy, and these educational initiatives should be not overlooked in the near future. The future consensus meeting for the discussion of other controversial topics are being planned, anticipating for an ever-growing production of selected and relevant scientific data. This is our next consensus task force. We plan to occur in August 2020 in Aracaju, Sergipe, at Brazilian Northeast. And we will be able to enjoy king crabs and iced beers, and hope to see you there. Thanks for your attention. Thank you.
Any questions for Dr. Canheu? Any questions?
Comments. Well, certainly this is the right direction. And I wonder if and the US can do this as well, if we can create a knowledge base. I'm sorry.
No.
Go ahead.
Yeah, go ahead.
Oh, anyway, briefly, to go along with the education piece is what changed these charts and these numbers. It's the education piece.
Yes.
And it's the education piece also that we need to think about a lot. That young neurosurgeon that's in a smaller community is going to do their first Chiari malformation surgeries. What's the agreed upon database, knowledge base? But maybe we can get to that later on.
Yes, thank you.
What was the average size of the decompression? I could see that Professor Canheu's suboccipital craniectomy was quite large. But what was the average size of the whole group?
Dr. Canheu, the question was, what was the average size of the decompression for the whole consensus group?
This particular case of the picture, the boy was bearing 1.5 Chiari. So he had a pretty overcrowded posterior fossa. Yes, as I told you, it was quite large for the lateral. Summing up, we are debating, and we suggest 3 or 4 centimeters up and lateral to the foramen magnum in an average of the Chiari 1 patient. But of course, we can change a little bit in the cases of you may have a more overcrowded posterior fossa.
Thank you.
Thank you.
That's fine.
Very nice presentation. If you want to decompress the cerebellar tonsils, why do you have to make your craniectomy so large?
Yes, briefly, as I told you, audience before, we should analyze specifically each case, because the case that was operated on, the child had 1.5 Chiari, was not Chiari 1, and the posterior fossa was pretty overcrowded, and we go on further on the decompression, try to get the dura mater more loose, so we couldn't do that, and the duroplasty was performed.